I'm going to go ahead and just say a couple of things. For those of you who don't know me, I'm Janet Titchener. I was here once before, seeming like a long time ago. Can everybody hear me okay? We are actually recording this session, much to my chagrin. However, I will take questions. I'm not going to rush through this, so please feel free to ask any questions. If I ignore you, it's because I realize I'm running out of time, and because we're being filmed, I have to just be a little bit conscious of how much time it is. Hold on to your question, and I can answer it afterwards, all right? A couple of other things are that first of all, this is part of a series. As some of you know, I've obviously got more than just what's called Train the Trainers in the room. This is part of a series of 8 modules, of which today you're going to get 2, but these are not the first 2, so presumably there was one you've already gotten. We've done that because we've had to arrange it in a special way because of the filming. However, hopefully each one of the modules can stand alone, but there will occasionally be something that I'm going to refer to that you might go, huh? And it's because it's the module that you haven't had before, okay? But it really shouldn't disrupt things too much. I'm also incredibly aware of the fact that I've got a room full of very varied backgrounds. I've got doctors, obviously, in the room. I've got nurses in the room, and we've got pharmacy in the room, and there is diabetes clinic in the room, which is fantastic. Anybody else that I've got in the room? Not only have I got really varied backgrounds, which means really varied understandings or background knowledge that you're going to bring to this, I've always got to assume that somebody's at the bottom rung, and so we're going to start right back at basics, of course, and work upwards. But the other thing is that some of you have sat in some of my teachings before. I'm sort of half apologetic because, again, you will be seeing a whole lot of stuff that you've seen. However, I'm actually trying to teach you 2 things here, not just knowledge and background and understanding of diabetes and pathophysiology and medications and things like that. I'm also trying to communicate to you some techniques that you can use for patient-centered care, which is what the whole push behind all of this education was for the patient-centered medical home idea that has currently in the workings. If you've got an increased knowledge and you're finding that I'm not adding a whole lot to what you already had, or if you've sat in my courses before, please take a step back and just take a little bit of a look at how I'm doing things, what I'm doing things, and hopefully pick up ideas on the techniques that I'm using. Occasionally I will point these out, possibly not so much today, but that's where it would have been quite helpful if you'd had the half hour prior to this coming into it. Okay? There is a manual, a draft copy of a manual. I was only given 20 copies of it. I was told that there were 20 Train the Trainers. So clearly there's a shortage of manuals. Please share, but I will bring some extra ones next time. This is only the stuff that is covering today. It is a draft, and I'm really looking for anybody who would be interested in helping me to edit it, to go through it, to add to it. It is really hard when I'm coming from, I already know what I'm doing, and I've written it, well, I haven't written it, but I've said it over and over again, and often we miss things. I would be incredibly interested if it was not just a doctor, but also a nurse and even a pharmacist looking and helping me look at this and adding what, or telling me what I need to add to improve it. Just as with the teachings that I'm going to be giving you, I have written the manual in a way that I don't just want to give you the knowledge. I am trying to give you tools and ways that you can present this information to patients in a patient-centered way. It is not the only way to do it. It's just giving you some ideas. So some of you may read the manual and go, well, this is kind of simplistic. The idea is that we are trained to speak in a foreign language. And it's very hard for a lot of us to actually understand how we can then translate what we're doing into lay language. And that is the idea of the manual, for you to be able to go and use it. And indeed, I've had patients read it, lay people read it, and they seem to like it. Okay? I think that's what... Oh, finally, for the Train the Trainers, I do want a way of tracking whether or not we're actually achieving what we're setting out to achieve. If you've please done a questionnaire that was sent out to you I'd love you to hand it in prior to starting, because obviously you're not supposed to have any knowledge. You're supposed to do really badly on this one. The next one is the one that you're supposed to do really well on. All right? Any questions? If I was in New Zealand, I'd have to tell you where the toilets are and where the exit is. I don't know, do I have to do that here? No. Okay. All right. As I've just said, you're all in this room from very varied backgrounds, and I just want to point out that there are two levels of information that I'm hoping to provide here. One is the basic general knowledge of the pathophysiology of diabetes, along with medications we're going to cover today. But the other stuff that I'm trying to communicate to you is, of course, the skills of how do you communicate this to the patient. For those of you who have been sitting in my classes before, who already have a good knowledge and understanding of management of diabetes, then just take a step back, and I ask you just to look at some of the techniques that are being used and seeing whether there's something that you would like to adopt when you're sitting in a room with a person in front of you. When you're starting to talk about diabetes with a person, whether they've had diabetes for 5 minutes, you've just informed them, or 20 years, you can never make the assumption that they actually know as much as you do, or that they're actually talking the same language as you are. And it's incredibly important to make sure that you start on common ground, that you're actually going to start in a place where they understand. With the people that I've been chatting to for years about diabetes, it actually all started in Quarryville, actually. I have very clear memories of drawing pictures on paper towels with my patients. And I always started out by saying, you know, your body is made up of cells, brain cells, liver cells, skin cells. And that's how I always started my story. And I'm a little bit embarrassed to say that it's only relatively recently, 2 or 3 years ago, that it occurred to me that maybe somebody doesn't actually understand what a cell is and that our bodies are made of cells. And I now start my story a little bit differently, and I go, so how comfortable are you with the idea or the concept that our body is made up of cells? Is that something that you understand? And to my amazement, actually to my embarrassment, my horror, I would say that about 90% of the people that are sitting in front of me have absolutely no idea. Please be careful when you start your story with your patients that they truly are on the same page with you. It's easy with me sitting in front of you or standing in front of you guys. We all know that our body is made up of cells. And as I say to the patient, our body is made up of cells. They're like little engines. We have brain cells that make us think. We have kidney cells that produce urine. And like any engine, our cells need some kind of fuel. And the fuel, of course, that our cells run on is glucose. The glucose seeps from the blood vessels and into the cells to provide them with their fuel. Very simple. Unfortunately, it's not quite that simple. The glucose has to go through a very special gate, and the gate is locked. And there are only two things that open this gate. One is insulin, and the other is exercise, if you're talking about muscle cells. So that if we don't have either of these, our gates aren't going to open, and the sugar is going to stay in our blood vessels, and it's not going to go anywhere. The car is an engine. It runs on a fuel. It runs on petrol. It'd be a pretty silly car if you didn't have a gas tank to store the petrol in, because you wouldn't be able to go anywhere. We also have a tank that stores our fuel, and our tank is our liver. And our liver stores about 24 hours of glucose, and actually it can generate enough to last for about 3 days, so that it constantly drips 24 hours a day. Drips glucose into the blood sugars, into the blood vessels, to make sure that we've got enough fuel in order to keep going for the day. Well, that's all fine and dandy, but we've got a gate here that's locked. And so on the other side of our body, we've got a pancreas. And it drips insulin 24 hours a day. It drips the insulin into here to make sure that it's opening up the gates But I've drawn it to match the liver because, of course, in a person who doesn't have diabetes, these two things are beautifully matched so that we've got just the right amount of sugar dripping into the blood vessels, just the right amount of insulin, keeping those gates open, matched beautifully by feedback loop systems so that we've got everything flowing beautifully and keeping our blood sugars in a very tight, narrow range. Anybody want to offer me what they understand is the normal blood sugars in a person who does not have diabetes? The normal range of blood sugars. 60 to 100. 60 to 140. Excellent. All right, 60. You'd be amazed at what you get from a person who has had diabetes for many years. More often than not, I get wrong numbers. 60 to 140 normal blood sugars. Any questions? Go back to the car. You go driving for 500 kilometers, 500 miles in this country, and you run out of gas. We also run out of fuel, and we also have to refuel. The way we refuel is we eat. And everything we eat, we're very clever, we can turn into glucose. The pancreas down here goes, uh-oh, I need to do something. And it does something a little bit different, and it sends out what we call a bolus of insulin. In fact, in somebody who does not have diabetes, before that food even hits your lips, that insulin has gone shooting out. You see it, you smell it, that insulin has gone shooting out so that these gates are sitting, waiting, wide open for this glucose coming down here, which is why we never go above 140. I repeat that. It's why we never go above 140. All right? If you don't have diabetes. What I'm hoping that you get out of this is that we've obviously got two different ways where our body gets its fuel from. And with that, our pancreas does two slightly different things in providing the insulin so that we can use that fuel, so that that fuel is available to us. So what's diabetes? Diabetes is when something goes wrong with the system. And if I was a little bit naughty for a couple of minutes and decided I'd like to make myself into some kind of powers to be and pretend that I was going to try and create the disease of diabetes for mankind, I could stick my pen anywhere in this picture and create a problem that's going to make the sugars go up in the blood vessels. Perhaps I could create a person who's got a liver that suddenly starts spewing out a whole lot of sugar. Or maybe I could create a person who's got a pancreas that no longer produces any insulin, so the gates don't open. Type 1 diabetes would be one of them. Perhaps I've got a person whose pancreas produces plenty of insulin, but there's something slightly wrong with the shape of the insulin molecule, so it doesn't quite fit the keyhole in the gate. Or maybe I could have a person who's producing perfectly good amounts of normal insulin, but the keyhole in the gate's the wrong shape. The receptor doesn't work very well. Or maybe I could just create a person who's got a rusty gate, insulin resistance. I could go on and on. And in fact, we now know that there are more than 50 different ways, more than 50 different types of diabetes, and it's growing by the minute. You have the most recent American Diabetes Association classification in your little manual there, which has, I think, over 60 listed at this time. It's just been produced this year. Type 1 and type 2 diabetes are, of course, the most common types of diabetes. Let's just go over them a little bit, because I think one of the most important things to understand is that even though you might be talking about a type of diabetes, it does not give you a clear indication necessarily of what the underlying pathology is that you're dealing with. Type 1 diabetes, of course, is when something goes wrong with the pancreas. And as you all know, it's an autoimmune disease. My fascination has always been, when I've discussed this with people who may have had type 1 diabetes for 20 or 30 years, is how few of them have actually been told the process. The fact that you have to have a genetic predisposition in order to get it. The genetic predisposition does not necessarily mean that you are going to get it. You then get an environmental hit. We believe that it's most likely the childhood diseases, childhood illnesses, but there are other illnesses that can also create it. You get a hit, your immune system gets revved up, it gets confused, like in any other autoimmune disease, and it begins to believe that something in the beta cell that produces the insulin is actually a foreign body, and it begins to attack. And therefore, you lose the ability to make insulin. All right? Any questions about that? Anybody want to ask? Type 1 diabetes, we have historically always thought of it as being a child's disease. We've always thought of it as being a skinny child's disease. They come in often, peeing a lot, losing weight perhaps, and with high blood sugars. Type 1 diabetes. Okay? However, we do have an obesity epidemic going on, and we have a lot of our children who are no longer skinny at the time that they get diagnosed, and in fact about half of the kids in some of the southern states of the United States who are receiving the diagnosis of type 1 diabetes, half of the 12-year-olds at least, also have type 2 diabetes at the time of their diagnosis. So we have a new term, double diabetes, out there. All right? I said historically we've always thought of it as a child's disease. We now know that we are wrong, and that adults can also have autoimmune diabetes. And in fact, half of the people, I should say more than half the people who have the diagnosis of type 1 diabetes are actually over the age of 30 at the time that they get diagnosed. And interestingly enough, about 4 years ago, we actually diagnosed an 86-year-old new onset type 1 diabetes. She came in complaining of very poor vision that had been worsening over time. We had a very exciting day where we ran fluids for 8 hours, brought her sugars down to a better level, and she thought we were miracle workers because her vision came back and she was able to read. But yeah, that was an amazing experience for us as well. It is not just a childhood disease. Any questions about type 1 diabetes? Obviously, if their pancreas is not producing insulin, you have to give them insulin. Type 2 diabetes, we have historically always thought of as being a problem with the gate, as I call it. We get a rusty gate. And when the gate gets rusty, it doesn't open very well, and so the pancreas here starts throwing out a whole lot more insulin to try and overcome the insulin resistance that they've got. And the person actually does very well for about 7 to 10 years. The pancreas manages to overcome the insulin resistance and keep the blood sugars more or less in a normal range. After about 7 to 10 years, the poor old pancreas down here says, I can't keep doing this. And it shuts down, or begins to shut down. And of course, when it begins to shut down, the gates stop opening properly, the sugars can no longer flow in, they begin to rise, and the person gets diagnosed with type 2 diabetes, keeping in mind that they've already been sick for about 7 to 10 years. So we've got a problem with insulin resistance. We've got a problem with a failing pancreas. There's a third problem that we've got, which is over here. When the insulin is no longer being produced in a high enough level to keep the gates open, the cells are no longer getting the fuel that they need, and they start to complain. What I say to the patients is, they kind of feel tired all the time, like they hit a wall. Maybe you're having problems with sleep, depression, crying, mood disorders, anger management. Usually at some point the patient's sitting there going, how do you know? All right? What we know is the cells start sending out neuroendocrine messages saying, where's our fuel? I say to the patients, the messages go to the brain. You and I know that they go to various message centers. They go, where's your fuel? And the brain goes, well, that's funny, and sends a message down to the liver and says, what are you doing out there, liver? We need some fuel. And the liver then sends out a whole lot of glucose, which of course is not what we need. What we really need is for these gates to be opened. So there's a third problem in type 2 diabetes. All right? There's a fourth problem that we've got in type 2 diabetes that has really only been clarified in the last 5 to 10 years since gastric bypass surgery started. Down here we've got a couple of cells called K and L cells. Why they're called K and L cells or not A and B cells, I have no idea. When we eat, the food gets digested and it comes down here, and these cells get stimulated by the glucose, by the food that's coming down here, and these cells do four things. They first send a message to the pancreas and they go, hey, we've got food coming down here, you better shove out a bit more insulin to make sure that we can absorb the glucose that's coming through. They send a message out here to the liver going, hey, we don't need you to send out anything here. Shut down a little bit because we've got another source of fuel coming down. They send out a third message to the stomach and go, slow down. We've got enough glucose coming down here. We don't need it coming at a fast rate. It slows our digestion. So it helps to control those after-meal sugars so that we never go above 140. And finally, it sends a message up to the brain here and goes, you're full. You don't need to eat anymore, to the satiety center. A beautiful kind of super controller of coordinating the whole system. And unfortunately, in type 2 diabetes, this gets lost. Fascinatingly, when somebody goes through gastric bypass surgery or some major weight loss, but gastric bypass surgery, even without the weight loss, this gut endocrine system miraculously comes back, which is why those of you who've had gastric bypass surgery patients, within weeks, they're off of all of their diabetes medications, their blood pressure pills, their cholesterol pills. It's quite fantastic to watch, and that's because this system has bounced back. That's what we believe at this point. All right? So there's the fourth problem in type 2 diabetes. Any questions about that? This is the same information that I give to patients. I haven't given you guys anything different. They have every ability to understand all of this stuff, and they are fascinated. I give them the same, every person gets the same information, every person gets the same picture that most of you got handed out to you, blank. And I may give them the same information, but in a different order. Because, of course, they ask questions as we go through. And I love to take the teachable moment so that they can actually take this on board. All right? A couple of points that I want to point out here is that the way I've presented this, you would think that type 1 and type 2 diabetes were very different diseases, and they are. They've got very different etiologies. Oh, I've missed out a piece. Let me go back a little bit. I said at the beginning that historically, with type 2 diabetes, we believed that it was about having a rusty gait initially. And we now know that we're actually wrong about that. We know that this rusty gait or this insulin resistance is highly associated with obesity. There's something about obesity that makes those gaits rusty. We don't actually know what it is that does it. We know that if a person gains weight, their insulin resistance is increased. When they lose weight, it's reduced. What we do know, however, is that whatever this pathology that's going on up here, it's also going on down here. And so that, and what it does down here is it's destroying the beta cells that are producing the insulin. So when I said that for the first 7 to 10 years when they're pre-diabetic, or before they get diabetes, for the first 7 to 10 years their pancreas is overproducing insulin, actually it's only the cells that are left behind that are overproducing insulin. Because at the time that you diagnose somebody with pre-diabetes, they have already lost 40% of their pancreatic function at pre-diabetes. At the time you diagnose diabetes, they have lost almost 60% of their pancreatic function. So type 2 diabetes is actually as much about pancreatic dysfunction or pancreatic loss as it is about insulin resistance. And indeed, I just read a paper yesterday that it is now very much coming out that this is the absolute requirement for you to get type 2 diabetes, not insulin resistance. Think of gestational diabetes for a moment. Gestational diabetes, we think of a diabetes that you get in your third trimester. That is the trimester where the hormones of the pregnancy create a huge amount of insulin resistance. Prior to that, you don't have a whole lot of insulin resistance. In a healthy woman who doesn't have gestational diabetes, she's going to increase her pancreatic function by 60% in order to overcome the insulin resistance that's created by pregnancy. In a woman who's inherited a lemon from her parents, she doesn't have the ability to do that. And guess what she gets? Gestational diabetes. Now, what we say is she's got a predisposition to getting type 2 diabetes later on. Why? Because she's got lifestyle problems and smoking and things like that that are going to contribute to increasing insulin resistance so that her pancreas eventually is unable to cope with that. At the moment, she's got pregnancy that's creating insulin resistance. The point is she's inherited a lemon. Type 2 diabetes is about pancreatic dysfunction. Lifestyle contributes to your ability to get it. All right? What I'm hoping you are beginning to see, and this is what I wanted to refer to earlier, is that there's beginning to be a little bit of similarity in my presentation between what's type 1 diabetes and what's type 2 diabetes. Type 1 diabetes is also pancreatic dysfunction. They've lost about 90 to 95% of their pancreatic function at the time that they get diagnosed with diabetes. A person with type 2 diabetes, about 60% of their pancreatic function. Remember I said that these guys too can be obese? Do they have insulin resistance? You bet your bottom dollar they do. How many kids at diabetes camp do I have every year who are also on metformin? All right? Remember I talked about that double diabetes. So they've got rusty gates. Is anybody who's obese got insulin resistance? Absolutely. Why do some of them, in fact most of them, don't have diabetes, at least at this point, maybe not in 2025. But at the moment, most people who are obese do not have diabetes. Why? Because they've got good pancreases that can rise to the occasion and cope with that. Okay? Increasingly, the difference between our types of diabetes are getting very grey. And because of that, and what you'll see is that we're using the medications very much across the barriers of the types of diabetes. You can no longer identify a type of diabetes by what a person is on. You can identify their pathology, but not what type of diabetes they've got. And that's one of the debates that's going on in the literature all the time. How do we identify or how do we classify diabetes at the moment? There are some other very common types of diabetes. Hemochromatosis is another one. It's a deposition disease where the person's unable to excrete their iron in their diet and they end up depositing iron throughout their body. And of course, one of the places they deposit it is in the pancreas. And so again, you get a lemon of a pancreas that no longer can cope, and the person develops what historically we called bronze diabetes because they got the brown skin from the iron. Often missed, hemochromatosis is a common disease. Always have a suspicion. In fact, there is one patient I have a very clear memory of in Quarryville. Was my first exposure to how poorly we can do as clinicians. He had all through his chart comments made about his elevated LFTs and how he must be an alcoholic or drink an awful lot of alcohol and he's not admitting to it. And why aren't his pills working? The truth of the matter is he had hemochromatosis that nobody had picked up on, and he ended up, unfortunately, losing a couple of toes, which was completely unnecessary because, of course, we can treat hemochromatosis by phlebotomizing people. Another type of diabetes that is becoming much more, we're realizing it's much more common than we had thought, is MODY, or much more correctly these days called monogenic diabetes. The way I explain it to the patients, which is a little bit simplistic, but I think it's good enough, and I think it's a really good enough way for us to really get a handle on understanding it is if you think about making the insulin molecules, the pancreas starts out with something called proinsulin and essentially makes the insulin in a stepwise fashion until it gets the insulin molecule. And at each one of these steps, there is a kind of an enzyme that helps that to the progression of the chemical reaction to go. And if you've got a problem at any one of these steps, a genetic inherited problem of not having that enzyme or not having that particular mechanism to go from one step to the next, you're going to end up with a bit of a bottleneck in your system. You might produce a whole lot of proinsulin coming down here, but actually what comes out here is only a little bit of insulin. It is a dominantly inherited gene, and what you find is that some people in the family inherit it. So they have very little insulin coming out here, and they look much more like a type 1. Or you might have a person who looks like this, and they sail through life pretty well, producing reasonable amounts, until they start getting some lifestyle changes and tax their pancreas a bit more, and then they hit the bottleneck gets in the way, and they often get diagnosed as having type 2 diabetes. So how do you pick up a monogenic diabetes? Is often you have multiple generations of large numbers of people at each generation having diabetes, some of whom carry the diagnosis of type 2 and some of whom carry the diagnosis of type 1. And it's usually a very muddly picture, and they've all generally got it at a relatively young age. The truth of the matter is that if you're going to have MODY or monogenic diabetes, you actually have it as a child, usually, but it's often not picked up. It's becoming, there are now 11 of them that have been identified, and they are different genetic issues, and this is, as I say, a little bit of a simplistic way of presenting it, but it's good enough for understanding it. Where the current recommendation is that if you are suspicious based on family history, you really should be sending off genetic tests for them, because there are some types of MODY that you do not need to treat. There are some that you need to put on insulin. There are also very important to identify other family members who may not be symptomatic, but you do want to actually figure it out when they're 10 years of age, because you don't want them needing amputations when they're 40. All right? Any questions about monogenic diabetes? Always have a red flag going up when you suspect that something's slightly not fitting a picture of type 1 and type 2 diabetes. We now believe that about 1% of all people with type 1 diabetes are misdiagnosed. They're actually monogenic diabetes. We believe that about 20% of people who carry the diagnosis of type 2 diabetes, 20% of people who carry the diagnosis, that's 1/5 of your patients, do not have type 2 diabetes. They've got either monogenic diabetes or they've got late autoimmune disease of the adult, which is similar to type 1 diabetes but has a longer honeymoon period of about 7 to 10 years. All right? That is an incredibly brief, rapid progression through the different types of diabetes. Anybody got any questions?
I think it would be helpful to know when to go for doses or more specificity or when to look for MODY.
Great question. So helpful to know, how do you figure out when you need to ask for the tests? Welcome to the teaching session that we're going to do, I think probably the 4th one, and that's where I'll start going through. So how do you figure out what your person's pathology is in front of you, and what are the red flags that should trigger you into doing that? It's not a simple thing these days, because we don't necessarily have good tests. A lot of it is about a clinical feel. Any other questions? I have written about each of these in the manuals as well.